The cervical spine consists of the 7 cervical segments, and they can be divided into the upper group, the upper complex, between the occipital condyles, the occiput and its condyles, the atlas, and the axis. Those 3 bones work together as the upper complex and give us a great deal of unique functional mobility. The lower cervical, typical cervical segments start at 2 and go down to 7. Now let's describe a little bit of the differences here. The typical cervical segments have a vertebral body which is concave and convex, and each segment interlocks with the other with the intervening intervertebral disc space. The superior surface of the vertebral body is concave from side to side, and then it's convex from front to back. The inferior surface is just the reverse. So when you put the intervertebral disc in between these 2 vertebrae, you wind up with a kind of a universal joint, and it can move in almost any direction. That which determines the motion in the typical cervicals is the facing of the facet joints. And they face backward and upward and are quite parallel to each other. With that universal joint type of relationship at the intervertebral disc and the vertebral bodies, and with the facet facings as they are, you wind up with the capacity to have flexion and extension, with facets opening and closing, and then you get side bending and rotational motion with the coupling which is always to the same side. So that in the cervical spine, the typical segments, you do not have neutral mechanics. It is constantly side bending and rotating to the same side. Our motion then will be flexion, extension, coupled side bending and rotation to the same side. If that's the normal motion, any of those could become dysfunctional. Since there are no neutral mechanics in the cervical spine, you do not get classic group dysfunctions. They're all individual segmental dysfunctions. There may be more than one in a row, but you will treat them individually rather than as a group. In the upper cervical complex, the anatomy is unique in that C2, the axis, has typical joint relationship on the inferior surface with typical facets, but its superior surface has 2 rounded convex shoulders for the articulation with the inferior surface of the atlas. Now what's unique at this joint is that when the cartilage is present overlying the inferior articular surfaces of the atlas, that cartilage is convex, and so is the articular surface of the axis. So you get a convex-convex relationship at this joint, relatively unique in the body. Most of them are convex-concave. The other unique piece of anatomy at the atlas axis is the relationship to the odontoid process. And there is a joint on the front side and the back side of the odontoid process, one for the posterior aspect of the anterior arch of the atlas and the other for the transaxial ligament. The junction of the occiput to the atlas is a relationship of the occipital condyles, which are convex from front to back, and they're convex from side to side. And they articulate with the superior surface of the atlas, where they are concave from front to back and concave from side to side. And notice, if you will, that the superior facets of the atlas are wedged anteriorly to fit the anterior wedging of the condyles, so that the anterior aspect of that joint is more narrow than the posterior. Now that anatomy provides for motion at the occipito-atlantal junction, COC1, of a lot of flexion and extension, but the side bending and rotation always couple to opposite sides. If it side bends right, it rotates left. If it side bends left, it rotates right, and vice versa. There is no other way to maintain the integrity of the COC1 joints and have that motion be anything other than that. So our coupling will be type 1 coupling or neutral coupling with side bending and rotation to the opposite side. Another piece of the anatomy and the biomechanics of the cervical spine that's very important is the relationship to the vertebral artery. Most of the complications from manipulation reported in the literature relate to neurological accidents from vascular insufficiency through the vertebral basilar artery system. Normally, a vertebral artery enters the cervical spine first between C6 and 7 transverse processes. Then it ascends through the intertransverse foramina until it comes out over the superior aspect of the intertransverse foramina of the atlas, curls posteriorly around the occipital-atlantal joint on that side. Then it curls anteromedially, penetrates the posterior occipital-atlantal membrane to join with the one from the opposite side to make the basilar artery. The vertebral artery then is at risk at a number of places. Here at 6-7, throughout its course through the intertransverse foramina, but particularly at the top because of the intimate relationship with the occipital-atlantal articulation, its relationship of rolling over the posterior arch of the atlas, and then the posterior occipital-atlantal membrane. Biomechanically, in rotation, and particularly in extension and rotation, you physiologically narrow the contralateral vertebral artery upwards to 90%. So you must be careful of any diagnostic or therapeutic maneuver which will put that vertebral artery at risk. You want to avoid rotation while in extension. Rotation in flexion is much more physiologically acceptable by the vertebral artery. The other thing you want to be careful of is putting compression over the soft tissues of the suboccipital region that could compress a vertebral artery within those soft tissues. Now, not everyone has symmetrical vertebral arteries, so that if you only have one that is patent and supplying here, if you rotated to the opposite side, you might constrict what little vertebral artery circulation the patient has. Be aware of the potential for that. Now, diagnostically, we will look at this cervical spine then in two areas, the upper complex, the lower complex, and treat it the same way. We'll treat upper group and lower group. Sequentially, we start from the bottom up, and we will make diagnosis and provide treatment appropriate for dysfunctions of the lower cervical spine, then to the atlas on the axis, then to the occiput on the atlas. Even though the COC1, C1, C2 junction here functions as an integrated unit, we will make diagnosis and treat it individually, level by level. The diagnostic process for the cervical spine started during the screening examination when we actively had the patient forward bend and backward bend, side bent right, left, rotated right, left, and made observations of the capacity to do that. If we have evidence that we need to do more definitive diagnosis of the cervical spine, we start in the lower segments and move from the bottom up. We will palpate for tissue texture abnormality overlying the posterior aspect of the facet joints and this deep gutter here, and we will get there by going through the plane of the splenius cervicis, the splenius capitis muscles, and that will take us down to the deep layer muscles in the cervical spine. Now, the anatomical structure that we will use for our palpation is this articular pillar, and I have it identified in black on each side, and we will use that rather than the transverse processes, which are way out in front and related to the scalene muscles and the cervical nerve root. This is not a good anatomical landmark to use. The spinous processes are quite asymmetric, bifid, and the ligamentum nuchae gets in our way, so that's not good. So we find that this works very well. Now, how do we find and know where we are in this typical cervical spine? The spinous process of C2 is very consistent. It's the first bump down from the inion on the back of your head. The next one down that you feel in the midline is the spinous process of C2. Just lateral to that is the articular pillar of C2, and then they go down one at a time, and they're basically the width of your finger. So if my second finger is on 2, 3, 4, 5. The other anatomical landmark easily identifiable in the cervical spine is the vertebral prominens, which is the spinous process of 7, and the transverse process is quite wide at 7. It's the first one that is easily palpable going down the side of the neck. You hit that one right there, so you know where 7 is. You can come up from there. That's 7, 6, 5, 4, 3. So starting either at 2 or at 7, you can find the articular pillars and put your fingers on each side. Now, for the diagnostic process, we need to evaluate forward bending, backward bending, and the combined side bending rotation to the same side. If we evaluate side bending by introducing translation from left to right in this fashion, we are closing the facet on the left side, opening the facet on the right side. That is left side bending, and we did that by translating from left to right. If I translate from right to left, I am closing the right facet and opening the left facet. By doing nothing more than the translation right to left, testing for side bending, if I meet resistance to translation, I have resistance of side bending, and I know the resistance of rotation is to the same side. They are always coupled in the typical cervical spine. Therefore, if I do that translatory movement when flexed, and then I do it when it's extended, I can test the capacity for the facets to open or close, produce flexion, extension, and the coupled side bending and rotation to either side. What we're going to do for our diagnostic process is put a contact point on a pair of articular pillars of a particular segment. This is 5 on 6. That's a very common area of dysfunction, by the way. And then we're going to flex it and extend it in relationship to the segment below. And then as we hold the head and the upper cervical spine together, we will translate this segment in relation to the one below. The one below is mobile. This one will be restricted because we're going to hold it with our fingers and interpret the motion capability of our C5 on C6 in this example. We will begin by identifying where we are. And the spinous process of 2, spinous process of 7. Drop our fingers symmetrically underneath the cervical spine in the fascial plane until we can get down to the pillars. Now there we can identify in that fascial plane any muscle reactivity deep in the cervical spine. Our patient Mark has some hypertonicity between 5 and 6 on the right side, very common. So I know that that segment is one I want to test. So I will put my fingers, one finger reinforced, on the pillar of 5, and I will introduce extension by lifting that segment to toward the ceiling. I'm not tipping his head way back, I'm just lifting that segment. When I first feel resistance to that movement, that's as far in his extension as it wants to go, I control the rest of his neck and head above that with the palm of my hands holding his head. and then I introduce translatory movement from right to left and left to right. Sense range, quality of movement during the range, and end feel. Extension, translation from right to left. That introduces right side bending and the coupled right rotation. Extension, translate from left to right. That is left side bending and left rotation. Now I need to test the capacity for the same facets to open. So we have the same contact point on the pillar of 5. We roll the head forward sufficiently to get first to the movement of 5 and stop there. Introduce translation right to left, translation left to right. Now, in Mark's case, what we find is the following. As we put our contact on 5, extend it, translating from left to right, that's a normal range, normal feel. As we extend and translate from right to left, we have reduced range and a harder end feel. That tells us that the facet on the right side is not closing as efficiently as it should. We have resistance to closing on this right side. It restricts extension, it restricts side bending and rotation to the right. We can then say the diagnosis positionally would be flexed, side bent, rotated left. In flexion, we found symmetry to our translatory motion right to left and no abnormal end feel. Therefore, we know that his facets will open physiologically, but he has restriction of closure on the right side. Now, we would need to develop a technique then to close this facet on the right side. Our diagnostic process demonstrated for us that Mark has resistance of extension, right side bending, and right rotation of C5 on 6, a very common dysfunction. This right facet joint does not close physiologically. We identified that by having the C5 segment taken into extension by lifting it to the ceiling, then in translation from right to left, which introduces the right side bending, we met resistance. What we will do to treat this with muscle energy is that we will put a blocking force on the pillar of 6 so that that will fix 6, and we can move C5 by various maneuvers of the head and neck to begin to take it into extension, right side bending, and right rotation. And we will use muscle energy, and he will attempt to flex, side bend, and rotate his head to the left, and we will resist that isometrically. On our patient, it looks like the following. I find that pillar of 6. Now remember, there is tissue reaction over that, which is quite sensitive, so you want to be careful that you palpate gently. When I identify that pillar, I then lift my finger toward the ceiling. At that segment, it lifts 6 into extension, 5, 6 being the joint now mobile. First extension barrier, I hold it there, and with my other hand, control his head and neck, and introduce a little side bending to the right, rotation to the right, to the barrier. And I localize that with a little translatory force from right to left with my blocking finger on that pillar of 6. So I lift, translate right to left as I roll his head a little bit to the right in right side bending and rotation. Now, Mark, if you'll just gently push your left ear to the left into my hand. Push left and relax. That's a left side bending effort. One more time, push left. Relax. This time, take your forehead and nod it forward. Nod forward, That's a flexion effort. We resist that. Stop. Push your forehead into my thumb. That's a combined left side bending and flexion effort. Relax. Anything that seems to work the best. And after each of those efforts, I increase the localization of extension, side bending, and rotation to the right. 5 to 6 applications of muscle effort are usually sufficient. In the cervical spine, we can even use eye movement as our activating force because of the relationship of how you move your eyes to the cervical musculature. In this instance, if I would hold the same barrier that I had before, all I need to do is ask Mark, look left hard, a left rotary effort. Now stop, that's even harder than I need. Just turn with your eyes, turn eyes. That's sufficient. Look straight ahead. And I have him look to the right and relax, look right. That makes it possible for me to take it into the barrier. Now look left. And look right, relax, or look down. That's the flexion effort. Look up and relax. I can take the extension barrier. Look down. That eye movement can be just as powerful at times as active motion of the head and the neck. Again, reestablish your diagnostic process to see if we have restored function to 5-6. The other dysfunction that occurs in a typical cervical spine is that in which a facet is closed and restricted in that position. Again, we will use C5-6 as our example, and we would have made that diagnosis during our process when we had flexed the head, translated from right to left, and met a resistance. The resistance is because this facet does not open, therefore we don't have right side bending in the coupled right rotation. Now our treatment procedure then will be to identify the facet joint of C5-6 on the right, block that with a finger to focus as a fulcrum, monitor on the other side overlying our dysfunctional segment for the tissue reaction during the muscle contraction, introduce forward bending, side bending and rotation to the right with some right to left translation, all designed to open up this facet on the left side. On our patient, we will support the head in the palm of my hand with this long finger overlying the right side facet joint and will act as the fulcrum. My thumb will be monitoring over the dysfunctional left C5-6 facet. When they're appropriately placed, the other hand will control the head and I will introduce flexion down to that segment. Then I will translate from right to left with my index finger until I feel the first barrier. At that point, my instruction to the patient is push left with your left ear. That's a left side bending effort. And stop. Or push your head straight down to the table. That's an extension effort and opens the facet on the left side. Relax. After each one, we take up the slack of flexion, side bending and rotation to the right to the next barrier. Push left ear left. Stop. Or we can use our eye movement again. This time I want you to look up at your eyebrows. Look up. That's the extension effort. Look down at your feet and relax. I can take up the slack into flexion. Look up at your eyebrows. Extension effort. Look down. Or I can have him look left. Look left. That's the left side bending, left rotation effort. Look right and relax. I can take up the slack to the right. Look left and relax. Again, 3 to 5 repetitions. We would then go back, flex his head to C5-6, translate right to left and left to right. to make sure that we have all of the facets at 5-6 have the capacity to close and open symmetrically. You would treat all of the typical cervicals, starting from 7 up to 2, 3, in sequence from the bottom up, wherever they were present. C5 is very common, C2, 3 is very common. Once you have the typical cervicals functioning symmetrically, in flexion, extension, side bending, rotation to opposite sides symmetrically, you can then proceed to evaluate the atlantoaxial joint. Once the typical cervical spine has been treated to balance, we are then able to proceed to evaluate the atlas on the axis. I've put a little black mark on the posterior arch of the atlas and on the axis for your orientation. Now we will be primarily interested in the ability of the atlas to rotate right and left symmetrically. That's the major motion that occurs at this level. About 90% of the motion of C1 on 2 is rotation. The rest are the minor movements of flexion and extension, side bending, left and right, and there is a cephalic to caudad translatory movement, up and down, as it rotates as well. We will test rotation only because any of the minor movements that are restricted will interfere with the capacity of the atlas to rotate. Our goal will be to restore symmetry of rotation left and right. On our patient, that is done by grasping the head and controlling the head and not putting your fingers on anything posteriorly, just the head. We will flex it up until we take out all of the flexion effort in the typical cervical segments. That becomes a rod around which we can rotate the atlas on the axis. We then rotate it to the left, rotate it to the right, looking for both range, quality of movement during the range, and end feel. And in Mark's instance, we have good motion right, about 45 degrees. That's about the normal amount. And he's about 30 degrees in left rotation. And when I get there, his muscle activity begins to tighten. So we have restriction of the atlas to left rotation. It is right rotated. Muscle energy procedure can be taken right from that point. We will just rotate his head to that first barrier, hold his head there, ask him to turn to the right gently, stop, stop, and relax. Turn right again, stop, relax. We take up more slack into the barrier of left rotation. Feather edge of that barrier, don't go too far. Turn right again, stop, relax. After he relaxes that second time, not just stops pushing, we can then engage the barrier. We can use eye movement also. Just look right. Look left. As he looks left, I can take up the slack. Look right, resist that because it's a right rotational effort. Stop, look left. Now look right again and relax. When we have done that 3 to 4 times, maybe 5, we'll go back and retest. Take him into the normal range. And we have improved the amount of rotation to the left of the atlas on the axis. Once that is restored, we can now proceed to evaluate the occiput on the atlas. There's a caution in this procedure that both diagnostically and therapeutically, you must maintain the head in this flexed position. Don't let it drop into extension as you rotate, to test or to treat. Keep your flexion, it's about a 45-degree flexion angle, and hold it there throughout the diagnostic and therapeutic procedures. This maneuver does not compromise the vertebral artery as it would if we took it into extension. So flexion is all right for the vertebral artery at this time. We can now proceed on to the cervical Atlanto junction, the COC1 junction, and evaluate that and treat that next. After restoring function to the typical cervical segments and to the atlas on the axis, we can finalize our evaluation and treatment of the cervical spine by going to the COC1, Occipito-Atlantal junction. We will again use our translatory right-to-left maneuver. While in flexion, we will hold the head, translate to the left, translate to the right, translate to the left, translate to the right. We want to hold the occiput square and have the atlas move underneath. In this example, however, when we do the translation from right to left, introducing right side bending, that introduces left rotation, not right rotation. In other words, COC1 couples to opposite sides where the typical cervicals in translation couple to the same side. So we will go into flexion and in extension, translate right to left, translate left to right, checking for the behavior of the condyles as they articulate with the superior surface of the atlas. We begin by grasping the sides of the head with our hands so that we can control a rotation forward and backward, a little nodding movement of the head. We envision that the head is going to rotate around an axis through the auditory nietae, and it's just a little rotation forward and a little rotation backward. We will start by rolling his head forward till the first barrier is sensed, with our fingers underneath the head overlying the posterior arch of the atlas. And as soon as that begins to move, we are at the flexion barrier of the occiput on the atlas. Then we'll translate right to left, left to right, right to left, left to right. Then we will roll his head into extension until we first begin to feel it close on the posterior arch. That's enough extension. And with that much of extension, I'm not putting the vertebral artery at risk. Here we translate right to left and left to right. Now what we're finding with Mark is that while in extension, translating from left to right is free. Translating from right to left, we meet resistance and restriction of range. That tells us that the occiput resists extension, right side bending, and the coupled motion of left rotation. We have not tested for left rotation. We infer that because we know the anatomical coupling that's present. The segment then is flexed, left side bent, and right rotated. We would then want to identify a muscle energy procedure to treat that dysfunction. Placing the head in our hands so that we can control the occiput with my right hand. And this portion of my index finger is overlying the soft tissue of the cervical atlantal junction. So I can monitor tissue tension with that. My other hand grasps his chin and lay my forearm along the left side of his head. I will therefore engage the extension barrier, hold his chin midline, then by side bending his head with my left forearm, I engage the right side bending barrier. Notice that I did not put rotation in as an active movement. In this position, I have engaged all three barriers, and I'll ask him, look down at your feet. Look down. Look up at your eyebrows and relax. And I can increase the extension and the side bending. Look down at your feet. Up at your eyebrows and relax. That's the eye movement that we used. We could also have given him the instruction to gently take your chin to your chest. That's the muscle effort of flexion, relax, or with the top of your head, tip your head to the left. Relax. That's a left side bending effort. I can increase right side bending and extension. Tip the top of your head left and relax. 3 to 5 efforts again, 3 to 5 second contractions. Go back, reevaluate. Translation, left, right, left, right, left, right. Had we identified any restriction in flexion, we would have to modify our technique to deal with a flexion restriction. Let us simulate for you on mark one in which we identified, while in flexion, translatory movement restriction from left to right. That would mean that the segment resisted flexion, left side bending, and the coupled right rotation. We would then grasp the head exactly the same way with it in the palm of the hand, but now we want to control flexion and left side bending. Flexion, chin midline, left side bending. Now, our efforts will be extension and right side bending. Look up at your eyebrows. Look down at your feet. Look up at your eyebrows. Look down at your feet. With the top of your head, tip it to the right. Relax. Tip it to the right. Relax. Or push your head straight back to the table. Push it back. Relax. Any of those efforts would be useful. We would try them all, or whichever one seemed to do the best for you. When you have treated out the typical cervicals and the atlantoaxial, occipital-atlantal joint, you should have freedom of total range of motion of the cervical spine to both sides. All joints need to participate in the activity of taking your chin to your shoulder symmetrically on each side. We've restored quite good motion to Mark's cervical spine, and it has good capacity to move in all directions. The high-velocity procedures from the cervical spine are also the same 5. We need a high-velocity procedure to close a facet, to open a facet in the typical cervical segments. We also need to have a high-velocity procedure for rotation of the atlas on the occiput. We need a technique for rotation of the atlas on the axis. And then we need a technique for the 2 flexion or extension restrictions in the COC1 joint, the occiput on the atlas, with the coupled side bending rotation to opposite side. So we have 5 procedures to do. The first would be if we wanted to close the facet on a right side. In our example here will be C5 on 6. We want to close that facet. Our procedure will be to put a contact on the pillar of C5. We will use the metacarpophalangeal joint right here as our contact point. And we will introduce extension and side bending by translation from right to left. And then we will introduce a thrusting force with high velocity, rapid acceleration, short amplitude, not very far. We want a 1/4 of an inch movement at that joint. Our thrust will be from our contact on C5 down to the spinous process of T1. Now this same procedure can be done in any of the typical cervical segments. The only difference will be the vector of force in direction toward T1. The lower you are, the more it will be in a horizontal. The higher you are, the more it's in a vertical direction to close the facet. A high-velocity procedure to open a facet, we want to take it in that direction, can be done one of two ways. One, we will block the facet joint on the opposite side, introduce flexion, side bending and rotation to the left, our contact point on this pillar, then in a rotary fashion, with our contact on this pillar, anteriorly and to the left, we'll open the facet, taking it into flexion, side bending and rotation to the left. A variant to that can be a contact point on the facet of the opposite side, then by just side bending and rotation to the left, we put a translatory thrusting force from left to right in that direction, and it opens the facet. Either one of those will be successful, and they are just variants of each other, whether you thrust this direction or you thrust from here. The thrusting procedure for the atlantoaxial, we will have a contact along the posterior arch so that when we want to rotate the atlas to the left, our contact point will be there and we will rotate it there. It is important that your contact be on the arch. In the COC1 articulation, high velocity techniques, we will engage our barrier and then with two hands, we will have a long axis force going in this direction to separate the condyles off of the atlas. One of the things we want to do in this area to be careful of is that vertebral artery. Therefore, we want no compression on the vertebral artery, and we want no rotation as part of the activating force. So as we engage our barriers, we will then use a two-handed long axis extension force or high velocity in that fashion. On our patient, we will start with his C5-6 restriction on the right into extension, side bending, and rotation to the right. We will put our contact finger on the pillar of 5. Takes a little while to work through the soft tissues until we get to the pillar of 5. Contact is there. This hand will control the rest of the head and neck. We will extend and translate right to left to introduce side bending to the right and rotation to the right. Now the paradox is that it looks as though I'm turning his head left. Well, I am, but that's the upper complex. At the segment I have the contact with, it is side bending right and rotating right. When I engage the barrier, I will then put a vector of force with my high velocity, caudate and medial in the direction of the spinous process of T1. And we just move quickly toward T1. Contact on 5. Extend, side bend, and thrust down to 7. To open the C5-6 facet joint on the right side, we have the two variations. The first one will start by putting a blocking finger on the C5-6 joint on the left side, put the contact point on the pillar of 5 on the right side. We now flex, side bend and rotate left. Notice how the top of his head is going to the left, so he's side bending left and we're rotating in left. We take up all of the slack. The thrust will be rotary with my right hand in that direction, pivoting around my contact on the left C5-6 facet joint. Contact C5-6 left, metacarpophalangeal, pillar of 5 right, flex, side bend left, rotate left, rotary thrust, to the left. The other variant to C5-6 right facet joint that needs to be opened, put our thrusting contact point, the metacarpal phalangeal, on the C5-6 joint to the left, flex, side bend, and rotate to the left, and thrust straight across. It's a thrusting force from left to right, which opens the facet on the right side. Having corrected all of the dysfunctions in the typical cervicals, we then go to the atlantoaxial. We go to the atlantoaxial joint. Now we will want to put a contact. He has left rotational restriction. We will put contact point on the right side of the posterior arch of the atlas. Same contact from here. Flex him up, rotate to our barrier, then we will fine-tune and fine play a little flexion, little side bending to get in the plane of the joint, and then take a quick rotary thrust from right to left in a rotary fashion which moves the atlas on the axis. Contact then is posterior arch of the atlas. Flex the head, go to the barrier, play around with the plane of the joint till you're in it, and that's a rotary thrust carrying the atlas into left rotation. The occipital-atlantal high-velocity techniques are localized in exactly the same fashion that we did for the muscle energy procedures. And that is, we will hold the head in our hand, cup the chin and the forehead. We will engage our barrier. The first one we will do is extension, right side bending, left rotational restriction. We will engage our barriers exactly as we did in muscle energy. Contact points are exactly the same. Extend, side bend, and rotate. Now for the high velocity, I want to be able to get two hands to do a long axis extension thrust. So I will shift my body to the side of the table in order to do that easily. Contact on the occipital bone, not the posterior occipital atlantal membrane. Hold the chin, side of the head. We extend, side bend to the right, chin midline, and then go straight toward the head of the table with two hands. Two hands came straight up. Again, contact occiput, chin, chin midline, side bend, two hands this direction. The other dysfunction we did in muscle energy was one that we had a flexion restriction. Same localization, same side bending. And now, just take it to the side, two hands straight up with velocity. The high velocity procedures would only be used if you had not had good response to your muscle energy procedures. The risks in manipulation of the cervical spine have primarily been the high velocity procedures. The ones we have demonstrated here are quite safe and do protect the vertebral artery. The cervical spine is very important to us in patients who present with not only stiff and painful necks, the classic cervical syndrome, but also those who present with symptoms from the cervical spine to the upper extremities, the so-called cervical brachial syndromes. And you should give your attention to the cervical spine in anybody who presents with any of the shoulder, elbow, arm, hand problems, because frequently that will be due to alteration in nervous system function from the cervical plexus and brachial plexus down to the upper extremity. The upper cervical complex that we have divided and shown you how to evaluate it segment by segment by segment, motion to motion. This is the area where we frequently find dysfunction in people who have cervical cranial syndromes or the cervical cephalgias, the headache syndrome patients. And this area is very difficult to restore normal function and to maintain it once it is traumatized, like in a motor vehicle accident of the acceleration-deceleration injury. This area has an exquisite amount of nerve endings, mechanoreceptors, nociceptors, for all of the tissues in this joint compared to the rest of the vertebral axis. Therefore, it is very difficult to maximally function it by biomechanics, and it also is difficult to reduce the nociception from this area. So if you approach the cervical spine from the perspective of a patient who presents with cervical problems, cervical brachial problems, cervical cranial problems, approach it from below upward, fixing all of the dysfunctions in the typical segments, C1, 2, CO, C1. You then can follow that with appropriate exercise and other medication programs to maximize the function of the cervical spine to reduce those symptom complexes. The cervical spine is usually the last area in the patient that you will treat, having already established maximal function from below, treating the pelvis, lumbar spine, thoracic spine, rib cage, before you address the cervical spine. There is an intimate relationship between the mechanics of the cervical spine and the upper thoracic spine and the upper rib cage that includes a lot of the thoracic inlet and outlet syndrome problems that we have. Not only those that go to the extremity, but those that go up and down with all of the important structures that go through the thoracic inlet. Caution in the cervical spine is understand the mechanics, put a proper and effective therapeutic force through it. Avoid both examination and treatment in extension and rotation. That's what compromises the vertebral artery. There is no need to put a rotary thrust in the occiput. There is no need to put compression at the occipital-atlantal membrane. Avoid those and you can practice manual medicine in the cervical spine effectively and safely.